look at some recognition, the different signs and symptoms, some of the different treatment and safety issues that we face in the out-of-hospital environment, and how we interface with those emergency departments, and then also those challenges of identification and data. So when it comes to emergency medical services, we try to take an approach in our education that is very focused on signs and symptoms, because unlike in the in-hospital environment, we don't have the ability to do a point-of-care drug screen in nearly every single case. So we have to rely more on what our eyes tell us, what the patient tells us, or by their actions, what they tell us, and different clues that we find in regards to the scene and interviews with other individuals who might be present. So when we're dealing with psychostimulants, obviously another big part of the substance abuse issues that we face, not only across the Commonwealth but across the country, are also related to opioids, and they present in ways that are almost diametrically opposed, or exact opposites in a lot of cases. So that's why we take a very focus on signs and symptoms when we're trying to identify what type of pharmacological issue that we might be dealing with from a substance abuse perspective. And ultimately, those signs and symptoms ultimately guide our treatment and guide how we're going to disposition a particular patient. So when we're dealing with psychostimulants, the most common signs and symptoms that we're looking for and that we interface with are increased heart rates, increased blood pressures. What we'll often see, particularly in cases of excited delirium, which is a term that you're going to hear me use a couple of times throughout the presentation, is increased temperature, sweaty skin, dilated pupils, which is once again one of those opposites from opioids, where in opioid situations, we're looking predominantly for the pinpoint pupils. Seizures, delusions, paranoia, superhuman strength, and other issues like that are common signs and symptoms that we as emergency medical services providers see from individuals that are having an overdose or a situation involving psychostimulants. So ultimately, we know that these stimulants, they mimic the effects of epinephrine and really stimulate the central nervous system. And that's what the stimulation of that central nervous system is what predominantly causes those signs and symptoms that we saw on the previous slide. Probably some of the most common psychostimulants that are reported to us as having been seen in the pre-hospital environment, and from my time as a provider, cocaine, crack cocaine, methamphetamine, and ecstasy. Over the course of the last couple of years, a lot of EMS education has been revamped to not only be able to spend more time in being prepared to identify these particular drugs, in addition to the signs and symptoms associated with them, but also having to deal with situations which are polypharmacy in nature. We'll see a lot of cases where sometimes we've got uppers, in this case stimulants, mixed with downers, sometimes opioids, and those individuals might actually present as an opioid overdose, and so we would give naloxone, and then the remaining pharmacological effects of the stimulant remain. So we're having to spend a lot of time on drug identification and how to handle those polypharmacological situations that we run into. This becomes even more prevalent when the end user isn't necessarily even aware of anymore of what they're actually taking. They think that they know what they're taking, but because of by very nature, by its very illicit nature of the drug trade, there's never any guarantees as to exactly what is being ingested. So, unlike opioids, when we're dealing with different psychostimulants, there's not a universal antidote like naloxone to be able to handle these situations and to immediately reverse those effects. And kind of as we already discussed, patients overdosing with a stimulant will present markedly different than those overdosing on an opioid. Although, once again, we can still run into situations where both may be present, and if we intervene on one part, then the effects that were maybe being subdued by the other piece of the polypharmacy might become more prevalent. In a lot of cases, care in the pre-hospital environment related to these psychostimulants is really going to be largely supportive and really focusing on a couple of different things. First and foremost, protecting the patient's airway and ultimately ensuring a safe environment not only for the responding providers, but for the patient themselves and for any bystanders that might be present. So those are the primary issues that we're going to be looking at. There are also instances and fairly frequent case studies of individuals with stimulant use also incurring cardiac damage, whether that be through cocaine use or habitual cocaine use and placing a great deal of stress on the heart. Those are also aspects that we have to look at in the pre-hospital realm in being able to assess these patients as a whole. And ensure that we don't have any other underlying medical condition which is being exacerbated by the substance that the patient is using. So one of the things, particularly related to stimulants, that has garnered a lot of discussion within the EMS community over the course of, I would really probably say, the last 3 or 4 years, is the phenomenon that we refer to as excited delirium. And excited delirium can have a lot of different causes, but one of those causes is psychostimulant usage. It got to the point where it was becoming frequent enough that we at the State Department of Health and our regional EMS medical directors and EMS physicians from across the state actually developed a standing protocol for our Commonwealth's paramedics, which is one of the highest levels of out-of-hospital emergency medicine, and it's Protocol 8002. And its sole focus is not only, it's not stimulant specifically, but is rather that condition of what we refer to as excited delirium, which actually has a very specific medical definition. And one of the primary aspects that we look at with this is something called an IMCRAS score. And we're really looking at how agitated is the patient, can they be redirected, and ultimately assigning a score based on a scale that looks at a couple of different factors. And in certain situations, what we'll do is, if it is determined to be excited delirium by that pre-hospital provider and the clinical criteria are present, we will engage in sedation to protect that patient and to protect bystanders and the providers themselves. But really, we're looking at the patient as a whole, because we don't want them to be able to cause themselves additional harm or additional damage by continuously straining against physical restraint, which is what the real previous standard of care was in these types of situations. One of the most common sedatives, or not really a sedative, in this case it would be a dissociative agent, which is commonly used by EMS providers and emergency department physicians across the country is a medication called ketamine. It's a dissociative agent which is predominantly used in cases of excited delirium, but here within the Commonwealth, we also use it in smaller doses, in non-associative doses of, for pain control, and we'll also use it in cases to assist with drug-assisted innovation by paramedic level providers. Now, some of you, particularly if you're involved in the public safety community, you might have heard a little bit about ketamine here recently. It's made national media quite a bit due to a couple of I'll say high-profile incidents that have occurred in states out west. And here in Pennsylvania, we have a pretty rigorous quality assurance and quality improvement process where regional medical directors and agency medical directors, which are physicians that oversee the medical care, if they utilize ketamine for this purpose, they're actually required to review every single case to make sure that it is clinically appropriate. So there are a couple of pharmacological tools that we have to kind of assist in protecting the patient in garnering control. But in terms of truly being able to quote unquote reverse an overdose, there's no magic bullet to this, as we frequently see with opioids and naloxone. So Protocol 8002, it's just part of our larger protocol manual, and we use as much as we can weight-based dosages, where we'll utilize 4 milligrams per kilogram, which is fairly standard in these situations, via an intramuscular injection. If it's given via an IV, then that that dose comes down significantly because you don't need as much to garner an effect in most cases. And we also caution providers that if there's evidence of a polypharmacological situation, such as the involvement of benzodiazepines to go along with the stimulant, we really implement that caution because we want to avoid any situations where we could exacerbate or induce a respiratory depression. And then there are the protocol also goes on to be able to utilize other pharmacological measures such as midazolam or Versed in instances where it's clinically appropriate. And ultimately, all of our EMS providers have the ability to contact a physician. We call them medical command physicians here in the Commonwealth. These are experienced emergency department physicians who are available for telephone and radio consultations to be able to handle out of the box or unusual situations that perhaps the EMS provider needs some additional guidance on. So I alluded a little bit to this already, but there really are some challenges from a data aspect using emergency medical services patient care reports. I'm very much an individual who's driven by data and numbers, but also stories. And it's very easy for me to be able to generate a report as it relates to suspected opioid overdoses. I can type into my reporting system, how many patients did we give naloxone to last year? So actually what you see on the left part of your screen is a map from 2018, which shows naloxone utilization by EMS by county. And it's very cut and dry. I can tell you by county, by each year, how many times EMS providers gave naloxone. I can tell you that as a state, 89% of the individuals who received naloxone by an EMS provider were transported to an emergency department. But I can't get to that level of specificity with psychostimulants. And it's because, there is no one single medication that we can point to. There's no really great reporting mechanism for the different types of substances that might be involved. Um, and if you were in my talk at the summit last year, this part will sound very familiar. But so I after the summit last year and kind of in between and getting ready for this one, I tried to take a harder look and try to see, well, is there anything that I could try to look at to at least be able to give a high level overview of maybe take a couple of pearls or be able to point us into a direction to be able to tell the story of what we're seeing on the front lines in emergency medical services. And so I gave that a go, and in taking a look at the fields that we had available, I ran essentially two different reports. And this first graph shows by month from January of 2018 through October of 2020. And what this field particularly looks at is if an EMS provider reported on a 911 call a provider's primary impression of either excited delirium or documentation of some type of hallucinogen. And we can see that, it kind of ebbs and flows almost from a seasonal perspective, if you take a look at it for 2018 and 2019. But in the later parts of 2020, we began to break really what our previous average was is of about 250 a month. But for the month of July of 2020, we far exceeded that average, jumping up to 350 in that particular month. And like I said, this was solely based on what the provider reports. And unfortunately, that provider primary impression field isn't a field that is always filled out. In a lot of instances, it might be left blank. It might be marked as not applicable or not recorded. And, that really hinders policymakers such as myself who are trying to inform the different communities of interest as to what's going on so that we can work to implement strategies to, reduce illicit drug use, but also to focus on where we need additional resources for treatment and ultimately support for these individuals in order to get them taken care of. So the other thing that we took a look at is we tried to examine EMS usage of these dissociative doses of ketamine within the same time frame and who did not have an intubation attempt documented. And this goes back to the case of we utilize ketamine for a couple of different things now, everything from pain to inhibition to trying to control those situations which involve excited delirium. So this is looking at the same time frame, and once again we start to see spikes in 2020, and that really relates more so to the protocol itself. In addition to that protocol, ketamine is actually an optional medication. It's not mandatory, so its utilization is not necessarily Commonwealth-wide. But so once again, though, we do see spikes in 2020. But interestingly enough, we actually see the largest spike is going to be in that June month, as opposed to the July month that we saw on the previous slide. So this is potentially an indicator of incidence of that excited delirium. And once again, psychostimulants aren't the only cause of that physical presentation, but it certainly is a primary drug. Then I tried to take it one step further because I was kind of curious to look at some demographics in taking a look at the same fields. So I apologize for the text being small, but I wanted to be able to kind of show them side by side. What we see here on the left is actually the gender distribution for individuals who presented with that primary impression of either excited delirium or a hallucinogen. And what we see is that the gender breakdown is essentially equal. It's essentially equal between males and females at 50-50. And this covers the same time period that we were discussing before of January 2018 through October of 2020. Now, what's a little bit interesting is on the right, that's the gender breakdown of individuals who received a dose of ketamine and did not have an innovation documented. And the gender kind of skews a little bit with about 60% being male and 40% being female. If I had to hazard a guess, because of what I'm going to show on the next slide, I really think that what you see on the right is actually more indicative of psychostimulant utilization rather than what is indicated on the left. And I'll explain why here in just a second on the next slide as I approach my last minute. So this is the age breakdown. All same provisions apply. The top one is, once again, by that primary impression. And when we look at the primary impression for this entire time period, we're seeing higher proportions here in the 70 to 89-year-old age bracket. And this is, I think, large in part because delirium itself is also a medical term and is often a term that can be utilized in geriatric situations where they have deviated from their base mental status. Whereas when we come to the bottom and we look specifically at the ketamine utilization, we see that the age brackets are more of what we expect and are in line with what we see with opioid utilization of those higher age brackets being in that 20 to 39-year-old age brackets. And Kathy, don't worry, I see the red light, and this is the last slide here that we'll cover. One of the things that we also look at from social determinants of health and health equity, we take a look at what is the percent utilization and the percent presentation of different socio-ethnic groups. And we see that in terms of primary impression that we've been discussing with the whole time, you can see the breakdowns there on the screen. 81% being white, 11% of patients being Black, 2% Latino, and 5% non-reporting. Whereas when we take a look at the ketamine utilization, 66% are white, 10% are Black, 1% Latino, and then unfortunately by the nature of sometimes incomplete reporting, 23% either being other or that field was not completed. So that concludes my presentation, and I believe we're going to take any questions at the end. So Kathy, I'll turn it back over to you.
Thank you so much, Dylan. That was a very interesting presentation. And next up, we do have Dr. Kraus. And again, I would remind everyone to please read the bios that are on the agenda. And also remind folks that if you do have a question, you can submit them in the Q&A pod at the bottom of the screen. So Dr. Kraus, we're eager to hear your presentation.
All right, good afternoon, everyone. Hopefully you can hear me. Yes, Kathy?
I can hear you, Dr. Kraus.
Okay, great. Thank you. All right, well, thank you to Dylan for his presentation, and a bit of what I'm going to discuss will overlap with what you just heard, and that's a good thing in the spirit of EMS and emergency physicians overlapping in our work and collaboration and partnership. So my name is Chad Krause. I'm a practicing emergency physician at Geisinger Medical Center in Danville, Pennsylvania, in the rural middle part of the state. And I'm also the vice president of the Pennsylvania College of Emergency Physicians. So thank you for having me. It's a great pleasure to be here today. So as far as disclosures, I have no financial or other disclosures related to the content of this presentation. The views that I will express here are mine and not those of either PACEP or my employer Geisinger. And I do always like to say this is the perspective of one emergency physician with some public health training as well, and who has some experience both here in Pennsylvania. I'm a Pennsylvania native. I went to medical school and did my training here, and then worked for a little while in Missouri and Texas, both states with significant psychostimulant challenges and problems. But I do think that, now being back in Pennsylvania, we're seeing many of these issues, as Dylan just concluded his presentation with some great data about the burden of this problem. But I think it is important to know the perspective, because all of our perspectives inform how we see this issue. So our objectives for my portion of this presentation will be to review a bit of the history and epidemiology of psychostimulants, describe some of the clinical effects that we encounter in the emergency department, and then discuss a bit of the acute management of psychostimulant toxicity in the emergency department. And again, this is going to overlap a bit with Dylan's presentation that you just heard, as well as some of the other presenters that you'll hear today and tomorrow. And I think that's an okay thing that we're overlapping. So psychostimulants have been around for thousands of years. Actually, they first appeared in traditional Chinese medicine about 5,000 years ago in the form of ephedra, is what it was called back then. And similarly, we know today as ephedrine, which was really described, again, thousands of years ago. Amphetamines were first synthesized in Germany in the 1880s, and then about 50 years later, 40 years later, were synthesized in Japan. They came into really widespread use during World War II to keep soldiers alert during combat, to decrease appetite, things such as that, really in combat mission style during World War II. In the 1960s and 70s, recreational use became a bit more common, and then really in the past 40 years or so, we've seen ebbs and flows, and more recently, really an increase in use and prevalence of psychostimulants. So these are some data from the United Nations. In 2016, approximately 34 million persons worldwide used, with 5 million folks dependent on amphetamines. And again, some of this is related to purity, higher purity, greater availability, lower prices. Some of this certainly you can go on the internet, either the dark net or the regular internet, and really find a lot of these substances available online. They're available widely on the street and at really a relatively low price. They're frequently mixed with other drugs, particularly opioids. And not only are they a big public health burden, but I think the individual impact is extremely important for us to discuss. And as an emergency physician, again, I see these folks individually with our EMS providers bringing them, with our community members bringing their families, etc. So although these are really big numbers, and we're going to talk about some other numbers, and data are really important, but I think within that we really have to consider and be cognizant of the individual impact that this really has on people that we see in the emergency department. This is from the DEA and just shows how the price of psychostimulants, particularly in this case methamphetamine, has really gone down, although has remained sort of inexpensive over about the past 7 or 8 years. and the purity has remained very high. So most of these are around 90% plus pure, and cost somewhere around $60 a gram for purchase. So relatively pure, relatively inexpensive methamphetamine now available kind of on the street all around the United States. This just shows, again, from the DEA, the same drug assessment that was published in December of 2019, that deaths related to psychostimulants have gone up considerably and markedly in the past 15 years. So the most recent data in 2017 is over 10,000 deaths around the United States related to psychostimulants. In Pennsylvania particularly, we know we have a very large opioid problem, and I think these data are very interesting related to mixing of psychostimulants with opioids. And particularly, you can see in 2017, there were 307 reports of speedballs or super speedballs. And essentially what those are mixtures of either cocaine and methamphetamine with either heroin or fentanyl or fentanyl. So the super speedballs being heroin plus fentanyl plus a psychostimulant, whether that's methamphetamine or cocaine, and the speedballs being cocaine or methamphetamine with heroin. So again, whether or not those are intentionally adulterated or if end users are getting drugs that they're not sure exactly what's contained in those substances, is a considerable challenge both clinically and I think for sort of mitigation and prevention efforts. There's a considerable burden on the healthcare system. These are Pennsylvania numbers. So between 2016 and 2019, about a 66% increase in amphetamine-related hospitalizations. In that same time period, about a 27% increase in cocaine-related hospitalizations. So I think sometimes we tend to forget that cocaine is a considerable player and a considerable variable to think about with psychostimulants. Sometimes I think we think of cocaine as a drug from the 1980s or early 1990s that left the scene, but cocaine is back and very commonly used across our Commonwealth. So some examples of psychostimulants, and I'll give the disclaimer that for any toxicologists or pharmacologists in the audience, I am lumping the psychostimulants fairly loosely in this slide and in my discussion. So a caveat and apology for lumping these together. But many psychostimulants have what I would call legitimate medical uses. So probably the two most commonly known trade names are Vyvanse and Adderall. You can see the generic names for those substances on the screen. But those are really used for conditions such as ADHD, or other sort of attention deficit disorder types of conditions, among others. So again, there are legitimate medical uses for some psychostimulants, and unfortunately some of these that have legitimate medical uses are also the same drugs that make it, again, into the illicit drug market, onto the street, are sold, although their prescription drugs are sold for illicit or recreational use. And then more commonly, we have a whole group of recreational psychostimulants, and I could include 3 slides or 4 slides probably of all of these. But some of the more common ones are methamphetamines, the MDMAs or mollies, or ecstasy, cocaine, and then the cathinones or bath salts. So 5 or 6 or 7 years ago, many of you who are in the EMS or emergency medicine community remember there was a considerable bath salts prevalence in our communities, in our emergency departments. Although that's faded a bit more recently, it still is certainly out there and still a drug of abuse among those patients and individuals using psychostimulants. So not to be forgotten are bath salts. These are some street names. The photo you see here, the image you see, are some names for bath salts. You can see the packaging seems pretty nondescript, seems pretty benign, but these substances are anything but benign. So these are a few of the street names: Ice, Speed, Crystal, Acid, Spice, and K2, which I won't focus a whole lot on, but these are really quote-unquote synthetic marijuana, although they don't resemble marijuana at all. They're essentially a chemical cocktail that are marketed, in quotation marks, marketed to end users as an alternative to marijuana or as a synthetic marijuana, although they're really not. They're really, again, chemical cocktails that are stimulants. So again, I could go through probably 3 or 4 slides of different street names for all of these psychostimulants. And again, I'm being pretty broad and inclusive when I use the term psychostimulants. And the reason for that really is that what we see, and as Dylan just described, what EMS sees, I think it's probably less important from a clinical perspective for us to know exactly what substance a patient took, and more important to know that it's a stimulant. Where the exact substance becomes more important is really from an epidemiologic standpoint, from abuse and recovery standpoint, and perhaps from a law enforcement standpoint, where we're trying to determine what's out on the street and what's dangerous on the street this week or next week. So again, there's a whole group of these that I'm being very inclusive and loose with what we're including. So there's multiple methods that folks use to ingest, we'll say, psychostimulants. One is inhalation, so snorting. Certainly some of these are now available in pill forms, and injections and intravenous methodologies are very common as well. And when bath salts were very common, and continuing now to injectable amphetamines and methamphetamines, one of the things that we really see that is maybe not a today impact, but frequently we see end users and patients who come to the emergency department who have skin and soft tissue infections, cellulitis. Sometimes needles break apart, and sometimes you'll have a retained needle in your arm or other site of the body where these drugs are injected. So outside of sort of that excited delirium and very amped up, for lack of a better term, presentation that we see with patients in the emergency department, there are several other side effects or sequelae of these drug uses that we see. And I think that's maybe one of the best examples for injection or intravenous use, is that we may see folks who come into the emergency department a few days or a week after use who have pretty significant skin and soft tissue infections, retained foreign bodies, etc., that can be very, very unfortunate and very serious, even to the point where people need surgeries, and even to the point of amputation in worst case scenarios. So I think it's important that we consider those outcomes as well, and not just sort of the folks who come in very agitated because they've used in the last few hours. So part of the challenge and why we see so many clinical effects from these substances is that they really impact a lot of receptors in our brain, and several of the neuroreceptors that control clinical outcomes. So serotonin, dopamine, and norepinephrine particularly. So as I mentioned, in World War II, these substances were used to decrease and suppress soldiers' appetites. And that's really because of serotonin receptors. And then dopamine receptors, this is why we end up with physical dependence, is because the reward system in our brain, which are the dopamine receptors, when individuals are exposed and use these substances, there's a positive feedback mechanism in our brain which tells us we should have more of that substance. And then norepinephrine, which is sort of what we see as Dylan described with that excited delirium, where we have increased heart rate, we have increased blood pressure, and again, the term that I would use is quote unquote amped up, that there's a lot of agitation, and people's physiologic system is really ramped up, and how we see them with increased heart rates, etc. So intoxication or toxicity with psychostimulants, and you heard a bit about this in the last presentation as well. And what I would term this is the high. So this is the high that individuals get and what we see when we see them in the emergency department, when EMS brings them, when their family or friends bring them, or law enforcement frequently bring them to the emergency department. So we see things like agitation and delirium, hallucinations and delusions. And I'll never forget a story of a patient who was literally found out in the middle of a highway wandering around with no clothes on, because they were having hallucinations and delusions. And thankfully that patient was not injured as a result, but really was completely delusional and seeing things that just weren't there. Again, to the point where they put themselves in danger of walking out into the highway. Certainly hypertension, high blood pressure we see very frequently. We can see very high fevers, a lot of increased heart rates or tachycardia, and truly we can see a whole range of abnormal heart rhythms or dysrhythmias. Sweating is very common in these patients. Dylan mentioned a bit about, there can be heart and vascular damage, both from long-term use, but even in the acute, in the right now setting. Myocardial infarction or heart attack is not uncommon in these individuals, even though they may be young and otherwise healthy. Kidney failure is very, very common. Electrolyte abnormalities, particularly hyponatremia or low sodium, and hyperkalemia or high potassium. Rhabdomyolysis, which is muscle breakdown, frequently again because these folks are so hyperactive that it's almost like an exercise-induced muscle breakdown. And then in worst case scenario, we see these individuals having seizures, having strokes, and in a coma. And again, all this can be sort of the quote-unquote high. And as we talked about, excited delirium fits sort of with some of these symptoms, although it's a condition unto itself. But you can see these are sort of the way that these individuals present. And to be quite frank, this can be very disconcerting and frankly quite frightening to see individuals in these states when they're brought to us or when EMS responds to a call to pick these individuals up. So withdrawal, or what I'll call the low, so we don't see this quite as frequently, although we certainly see it after individuals, we've taken care of them and treated them and sort of brought them down from that high. They can become very sleepy, have really deep sleep for hours and hours. In the longer term, we can see individuals who have not had sort of the amphetamines or the psychostimulants that they're used to come to the ED with lots of cravings, with depression. And for some of these psychostimulants, their impact on the brain can be so severe that they really have prolonged withdrawal. Even cases up to months of withdrawal have been reported in individuals who have been using these substances for an extended period of time. So really our treatment, and I think Dylan touched on this, but I'll highlight the primary focus really is safety. And included in that I have airway protection as a third bullet here, but really safety includes airway protection. It includes safety not only for the patient, that individual, safety for whether it's our EMS colleagues, whether it's law enforcement, whether it's the public in general. Safety is really paramount, and primarily safety for the patient whom we're taking care of. Dylan mentioned the emergence of ketamine as a treatment, certainly a treatment. I would argue and say benzodiazepines are still our primary cornerstone treatment, although again things like ketamine certainly play a role, and there are other medications that play a role as well. Sometimes these people need to be actively cooled. Their temperatures become so high that they actually need active cooling, so IV fluids, fan, etc. And again, I think an interdisciplinary approach, and that's why I mentioned some of the overlap that Dylan presented with this, I think is completely appropriate because it really is an interdisciplinary approach. From when EMS is called or a family brings the patient to the ED, all the way through to outpatient, whether the patient needs inpatient or outpatient treatment, really the beginning of sort of outpatient therapy, getting folks enrolled in programs where they have addiction medicine specialists, etc. All of that, it's really interdisciplinary. And in the emergency department, as an emergency physician, I'm a part of that continuum of care, but certainly not the beginning or end, certainly part of the continuum. So again, I mentioned a little bit a few slides ago about that folks can get things like skin and soft tissue infections. So it's not all about just managing that excited delirium, that amped up state, the high, but really the impacts of this spill out into the community quite considerably. So I share this story as I come to a close with all of you, that about a year and a half ago, it was a late spring morning in May of 2019, and I was going to one of my shifts in Danville, and some of the roads were closed to get to the hospital, and you could smell that there was a fire, and this was the story, is that there was a clandestine meth lab, which, as all of us know, these are a very common and unfortunate reality, is that many individuals are producing methamphetamines and other psychostimulants essentially in a single pot on a stove. And this was one of those cases, and this was a house fire that injured several people. As this story said, this person was critically burned. But this is more than just managing the high. So this was a patient who, although did not come and receive treatment for psychostimulant abuse, this patient ended up being a severe burn patient. And so, this, I think, is, again, as we think about the impact of methamphetamines and psychostimulants that we see in emergency departments, that EMS sees, it's more than just managing that high. It's managing all of the impacts of this in our community, whether it's fire, whether it's EMS, whether it's police, whether it's the emergency department, whether it's burns, whether it's the high, whether it's skin and soft tissue infections. So I think that's, again, the importance of why this is really an interdisciplinary approach, is it's more than just managing that high and keeping the patient safe during that short period of time. So a few take-home points. I think, again, these are widely available substances, unfortunately. They're frequently combined, as I mentioned and Dylan showed you, the combination of psychostimulants with opioids, whether it's intentional or someone uses that they don't really know what they're using. They anticipate they're using a psychostimulant, but in reality, it's combined with heroin or fentanyl, which is particularly dangerous, because then this already wide range of clinical symptoms and presentations just becomes more challenging when you have quote-unquote uppers like psychostimulants, and then things that suppress airway, etc., like opioids, becomes very challenging from a management perspective. These patients require rapid assessment and stabilization, again, with things like ketamine, with things like benzodiazepines, again, with safety, immediate safety being the most important priority. And again, the interdisciplinary approach. I tell you, this is my perspective as an emergency physician with an eye towards public health, but it really is something that extends before the doors of the emergency department and after the doors of the emergency department, as well as in the emergency department. So I think that's my closing slide, and this is my contact information if anyone, I know we have time for Q&A now, but if anyone has further questions, this is my contact information, and I'm happy to answer questions or discuss further offline if it's something we don't get to today. So Kathy, that's all I have, and thank you all again for your attention and for joining us today and the opportunity to share a little bit of your time.
Great, thank you so much, Dr. Krause. There is a final poll question for our participants. And no questions actually came in through the Q&A. I am curious, though, you really stressed about the interdisciplinary approach and keeping folks safe. And, we have really been about the warm handoff approach and transitioning folks from the ED to substance use treatment. And the focus over the last several years has been that transfer to treatment for opioid overdose. Do you see that being the case for folks coming in on the psychostimulant substances as well, Dr. Kraus?
So I do. I will say I probably individually and in the systems I've worked in, particularly in the last 4 or 5 years, I can't express enough appreciation to the CRS workers, to the peer specialists who help with those warm handoffs and getting individuals from the emergency department into appropriate treatment options, of which there are many. And our organization, the Pennsylvania College of Emergency Physicians, has had a great working relationship with the PA Department of Health with getting those warm handoffs up and running. And there's really great models across the state. And whenever I have a patient who comes in with any sort of substance use disorder, I really use that resource and reach out to those CRS workers to do our best to get individuals into treatment options that are available. I think that's a wonderful resource, and again, from an interdisciplinary perspective, and really trying to get that patient the next step of treatment that they need, because again, what I do in the emergency department is largely stabilization for patients with psychostimulant intoxication or toxicity, to use that phrase interchangeably. But really, the bigger issue is what happens to them after their emergency department visit, which is, in my mind, far more important than my stabilization.
Yeah, well, it is a whole person approach, and actually, you see the progression from the work of Dylan and EMS folks and the folks that are treating, picking folks up at the site of the crisis and at the response, and then bringing them to the hospital, and then hopefully getting folks the treatment and the care that they need post discharge from the emergency department. So, it takes all of our disciplines to get people the care that they need. And so that reinforces all of the various folks who are represented in attendance at this symposium today, and learning from one another, and having a deep respect for all of our disciplines. So I do thank both you, Dylan and Ferguson, and Dr. Kraus, and all of our attendees. We only have 2 minutes left, but I would think that if you do have questions that come to your mind after you have a chance to digest the information, both Dr. Kraus and Dylan have left you with their contact information, so you can reach out to them personally that way. And I think you can gear up and get ready to go back for the next plenary session. And thank you very much, gentlemen, for your very informative presentations today.
Thank you.
Have a great afternoon.
just want to let everyone know that may still be on the session that we are going to be closing the session now. You'll want to return back to the main room for the next presentation. I'll leave this open for just another moment, and it will be shutting down. Thank you.